All right, thank you all for being here. If you jumped on a little bit late, if you don't mind putting your name and agency or organization in the chat, just to help Kim with the attendance, that would be great. And at this time, I am going to turn it over to Joanne Moore, who is the director at the Duxbury Senior Center. And Joanne is going to talk about a mini grant program that they did during the pandemic, thanks to funding from SSCPP. So Joanne, I'll turn it over to you.
All right.
You do have a PowerPoint.
Can you see my screen okay?
Yep, it's coming up now.
All right, so it's so nice to be here today. I'm Joanne Moore. I'm the director of the Duxbury Senior Center, and I'm here to talk about the PPOD program. I'm so thankful to the grant for $3,500. It enabled us to implement a program to reduce social isolation during COVID. So what happened was we could tell as the pandemic wore on, people were more isolated and lonely. So our social worker, Donna Chikina, reached out to make a list of who was isolated. And we also put a note in our newsletter, and people self-identified as being lonely and isolated. So we started this small group with funds from the CHNA and the Grafton Foundation. And I'm pleased to say for the last 54 weeks, we've been offering this program. So we have 18 people participating. They come 1 day a week for 4 hours a day, and they participate in a wide range of activities. They come here for social, let me go down to my next slide. Oops. Hold on. Next slide. I have two computers going, so I'm trying to get my mouse. Oh, there. So the purpose of our program is to provide individuals who identified themselves as being lonely a place to come that was both safe, fun, and rewarding. So our program included socialization, educational programming, nutritional meals, conversation, exercise, and recreational activities. It really was a terrific program because people who didn't know each other previously started to get to know each other better, and they got to choose the kind of programs that they really were enjoying most. Some of the accomplishments of the program is really strong friendships were formed. People in their 60s through 90s really became friends. And instead of just getting together once a week for the program, they now go out. They went out on a boat just last week. They play bocce during the week. They have dinner together and come to other programs at the Senior Center. What we're so proud about during the last 54 weeks, people who participated stayed healthy and safe. We helped them get their COVID vaccine through the Med Spa in Kingston. They were one of our first groups to get the vaccine because they were coming in the building, and we wanted to make sure they were doing that safely. We helped to reduce loneliness and isolation. Some of the individuals did live with family members, but many lived alone. And as everyone's world got smaller, they wanted a way to connect. Because people really enjoyed coming, we had really low participant turnover. We had 4 people who left. 2 were due to health reasons, and 2 family members felt that it wasn't safe for them to participate outside the home. And I think one thing that's really exciting is its increased participation in other programs at the Senior Center. These individuals may have been first timers to the Senior Center or would come for 1 or 2 programs. Now they're here almost every day of the week participating. This program will go on to December. And our program leader, she's in the middle with the kind of the auburn colored hair, Carol. She will lead a self-directed group once a week, so the group can still get together for coffee. But since they're so connected to the Senior Center now, we know that they'll continue to participate even as the program concludes. Let me get my last slide. So we are so thankful for the support of this program. This program has provided older adults for the opportunity to meet really great friends and make close connections. That doesn't always happen as people get older. People have a lot of losses, and this program really has changed that. The center has been able to provide significant emotional, social, and physical impact on the participants, and they feel positive about their overall health and well-being. And I'm so proud of our program coordinator for what she has created. She was like a school teacher who wasn't a school teacher when she started it. Every day she had program plans developed so The classes were interactive, fun. People were learning new skills. They learned how to Zoom. They had exercise. They had lunch in community, and then they helped to plan the curriculum for the upcoming week. So it really has been a wonderful program, and I am so thankful to the CHNA for their support.
Great. Thank you, Joanne.
You're welcome.
You answered my main question, but maybe you could talk some more about it. I was wondering if you brought in new people who had not been active in the senior center before, and I guess my follow-up to that would be, how did you find those people? You know, how did you reach out to them if they had been only tangentially involved with the senior center prior to the pandemic?
Sure. So I would say our community service manager had her pulse on the ones who needed connection that were already involved with the senior center, but really it was advertising in our newsletter, and people just came forth. One of our oldest participants is 92, and she just said, I live alone and I'm lonely. And it has really been rewarding and wonderful for her. So they have developed a bocce team in the backyard, and it's it's members from this group. So there's the Bocce Hall of Fame match later this week that they'll be participating in. And June's going to be recognized as the oldest player at 92. So she's really, her life is richer. She has lots of friends. I think we even have one dating match going on through this. Little romance has bloomed. So it's been really wonderful to see just the joy that this program has brought to others.
That's great. Does anyone have any questions for Joanne? And I know, Joanne, before folks came on, we were talking a little bit about your current status in terms of open/remote. You want to talk a little bit about that?
Sure, we are fully open, but we are doing things in person, remote, and hybrid, which has been a learning process for all of us the last 2 years. Some people, what I think has been really interesting in our fitness classes, we're doing both in person and remote, and where the instructors remote and the people are in class. So we have 3 different things going on. But one of our participants who had a hearing challenge said, I love taking the class at home because I can turn my volume up loud on my computer. I'm not bothering anyone. I'm having a much better experience. And it's like a one-on-one class. So we found that wasn't something we thought we would find, but we've found that some people love the remote. I'm away on vacation. I have a cold. I don't want to come out. So I'm able to participate in a different way. The next thing we're working on, we have just submitted a grant to a local foundation, and we're going to work on doing on-demand classes. So if I'm babysitting my grandkids, but I'd love to go to the yoga class and I can't do it at 10 o'clock, you can log on later on in the day when it's more convenient for you. So I think the pandemic has caused us to change the way we offer services. I don't think Zoom's going away. It's just going to be part of our business process. So, but things are good. Our social day program's up and running. So we have a day program that's for people living with Alzheimer's disease. So if you know anyone who's in the early stages, we do have some openings there. We provide transportation, nutrition, a vast amount of programs, and information and referral. As I was saying to Michael before the program started, our licensed social worker is retiring after 14 years at the end of the month. So if anyone knows anyone who is looking for a job in community, I will send the job description. But it's a great job in the community, and we're looking for a new team member.
Excellent, thank you. Now, I know other senior centers have memory cafes for folks with early onset, or even further along in the disease. Is that similar to program to that?
So our day program is a 6-hour-a-day program. You either come Monday and Wednesday or Tuesday and Thursday. We do partner with the South Shore Conservatory. They have a memory cafe. They are doing it at the conservatory, but as in January, we're going to offer it once a month here as well.
Great, excellent. Thank you.
You're welcome.
Does anyone have any questions for Joanne? I'm trying to see if folks want to unmute themselves or put it in the chat, whatever you feel comfortable with. Okay, well, I don't see any questions, but Joanne, thank you so much. I think it's we were really impressed by the grant when it was submitted, and definitely saw that it was something that was needed. for folks who were isolated. So we're glad to hear back that it was a success, and we hope that it's keeping connections going for those folks. So thank you. I think we do have one question in the chat about transportation.
Sure.
It just says, how do you work transportation?
Sure. So we are a subcontractor of GATRA. So we have 3 buses on premise, and people would just call the senior center and sign up, say they needed transportation. I did reach out to Joanne at GATRA yesterday. If anyone's interested, there is some Uber and Lyft money available if people are looking for that kind of transportation. So our transportation, people living in Duxbury, if they're going to surrounding towns, so that would be Kingston, Marshfield, Pembroke, and Plymouth. We would schedule rides directly for them. Great.
And there is another question about, is this program for Duxbury residents only?
It is for Duxbury residents only.
Okay.
Although we do take students to like Reach, ARC, and to their places of employment. So young people living in Duxbury as well.
And the money for Uber and Lyft is through the Taking People Places program, which started out as a grant. I think that GATRA got 2 or 3 years ago, and they've been able to continue that with some other funding, which I know Plymouth Senior Center is also involved with that too. Adult Center for Adult Living.
Right.
Yeah. Okay. Well, Joanne, thank you so much. We really appreciate
Thank you for having me.
And as I said, if you want to send that job listing to us, and also if you can send me the PowerPoints, we can use that on our website as well, just to let folks know about the grant.
Okay, great.
Excellent. Thank you so much.
Thank you.
Okay, so I'm going to turn it over now to Siobhan McKay, who is a steering committee member and a registered nurse and works over at DDS. And Siobhan does a lot of trainings for her colleagues at DDS, and we are leveraging that for our general meeting presentations. And Siobhan has put together a presentation on vaccines. And as I was saying before, Siobhan, something that is certainly top of mind for a lot of people, and working with patients and clients and consumers. And it's always good to have the sort of the latest information, which is changing every day as it happens. But so Siobhan, I'll turn it over to you.
Thank you. And can everyone hear me?
Yep.
Okay. I was having issues with my headphones. So I'm going to share my screen. Oops, hold on. The beginning. Share. Okay. And can you see that?
Yep.
There we go. Okay, so I'm going to talk about vaccines, boosters, and also some potential treatments that are coming up as well. So just to talk briefly about the types of vaccines, there are several different kinds of vaccines. The most common are the virus vaccines. Those are your live attenuated or weakened vaccines. And then also the dead virus vaccines. Those that's what most of our vaccines that we have are made. That's the type that they are. They do require extensive safety testing because they are live and weakened or dead viruses. So it takes a long time for these to be developed. It takes several years to do some testing on the safety. So it's not great in a pandemic for this type of vaccine. We also have protein and subunit vaccines. That's like your hepatitis B, your HPV, tetanus, diphtheria. The newer vaccines are the nucleic acid vaccines, and that's the Pfizer and the Moderna are nucleic acid vaccines. And then kind of a subcategory of that is the viral vector vaccine. It's a recombinant viral vector. That would be your J&J. So they are relatively new vaccines. However, they have been studied for decades. So they're new, but they're very safe. So mRNA vaccines, that technology has been studied since the 1990s. It's conventional vaccine approaches, again, don't lend to the rapid development and large scale manufacturing that mRNA vaccines can. They are non-infectious and non-proliferating, meaning that there is no way that they can cause the infection that they're vaccinating against. So they can stimulate a broad immune response. It's excellent vaccine stability. And again, that large scale manufacturing that you're going to need in a pandemic. So how do they work? The messenger RNA, mRNA, it tells your cells in your body to make a coronavirus shaped spike protein. And then our immune system reacts to that protein and builds immunity to the disease. The mRNA message degrades in your body. A lot of the younger kids are calling it like Snapchat. It just goes away. I like to say it's like the message from the chief in Inspector Gadget. It just self-destructs. So it's not going to sit there forever. That's what messenger RNA does its job, and then it goes away. The immune cells in your body will remember how to destroy that spike protein if they ever encounter them again. So there's no infectious particles in the mRNA vaccine. You cannot get COVID from the vaccine. And the mRNA does not get into your DNA. That was a false news story that was kind of making the rounds. So it's not going to change you at all. The recombinant viral vector vaccine, that would be the J&J vaccine, that uses a small piece of genetic material from the virus, from COVID. It's, again, non-infectious and does not replicate in the body. And the adenovirus vector, that the vector is the means to get it into your body, has been modified. So that also cannot replicate or cause illness. So this has another piece of genetic material that goes in and teaches your body to respond to the coronavirus spike protein. So again, for this one, they added that gene for the spike protein to a modified adenovirus. It reads the genetic material and creates the mRNA, which tells the cell to produce the spike proteins. The immune system reacts to the protein, builds immunity, and then again, you'll know how to destroy the spike protein if and when they encounter them again. Adenovirus-based vaccines have also been researched for decades. The DNA is not as fragile as the messenger RNA. So, and the tough protein coat from the adenovirus helps protect the material. So this one can be stored a little higher of a temperature, which makes it a little easier to administer, especially in rural areas. So I was very excited when this one came up as authorized. So a lot of questions have to do between the emergency use authorization and approval. From the FDA, an emergency use authorization, it's a mechanism to facilitate availability of medical countermeasures, including vaccines, during public health emergencies like the COVID-19 pandemic. So there are no safety shortcuts. There's no shortcuts between, there's very little difference between an emergency use and a full approval. For the emergency use, the FDA and the VRBPAC, it's the Vaccine and Related Biological Products Advisory Committee, which is a mouthful. They review safety data from phases 1, 2, and 3, and they include data for at least 2 months follow-up. They review chemistry, manufacturing, control information, as well as quality and consistency. And again, the safety and efficacy benchmarks are very high, that you have to meet a really good burden. Efficacy benchmark for us was set at about 50%. We wanted something that had at least 50% efficacy, and they were completely exceeded by that at 95. So the Pfizer and BioNTech one was granted EUA on December 11th for persons 16 years and older for the prevention of COVID-19. It was then expanded several months later in May to include 12 to 15-year-olds, same dose, it's 30 micrograms. And then it was expanded for a single dose booster for Pfizer and BioNTech on September 22nd to be administered at least 6 months after the completion in select populations. And the original study was 43,000 participants. And since then, millions, if not more, throughout the world have gotten this vaccine as well. Primary endpoints, again, were efficacy of the vaccine against symptomatic or severe disease, COVID-19, and safety. And it was found to be 95% effective. The participants ranged in age from 16 to 91 years, and that's why this one was authorized for as young as 16. Half were male, half were female. 82% were white, 30% were Hispanic or Latinx, and 10% were Black or African American. 5%, just under 5% were Asian. Interval between these doses is that 21 days. So after that first 7 days, the efficacy was about 52%. But then 7 days after that second dose, it rose up to 91%. And then 2 weeks after that second dose, we're getting to the almost 95%. So the Moderna vaccine, also mRNA, 2-dose. On December 18th of 2020, the FDA granted the EUA for 18 years and older for the prevention of COVID-19. And then on September 1st, Moderna submitted an application to the FDA for a booster shot. That hearing is scheduled for tomorrow, Thursday, the 14th. So their data showed a third dose given 6 months after the initial 2 doses significantly boosted immunity. They actually studied 2 different doses. The Moderna shot is 100 micrograms, so it's 3 times as large of a volume as the Pfizer. And that is given in 2 doses as well. The booster that they studied a 100 microgram, which is the same as their current vaccine, but they also studied a 50 microgram. And they found that the 50 microgram actually did a really good job at boosting the immune system. So it's likely that that 50 micrograms is going to be the one that they will get authorized. Again, they're meeting tomorrow to discuss amending the emergency use authorization of the Moderna vaccine for the administration of a booster in 18 years or older. And it's likely that theirs will probably follow the Pfizer with the special populations. And then as more data is given, it will probably open up to the rest of us. So their original study was 30,000 volunteers, but again, since then it has been given to millions of people throughout the world. Primary endpoint was prevention of COVID-19 illness. The vaccine showed a 94.1% efficacy at preventing COVID-19, including severe disease. And for them, their participants ranged from 18 to 95 years. So again, that's why the 18 was their lowest. About 52% were male, 47% were female. 80% were white, 20% were Hispanic, 10% Black or African American, and just under 5% were Asian. For this vaccine, they did also stratify who had comorbidities and what they were in the study. So they had people, 5% had chronic lung disease, 5% had significant cardiac disease, just under 10% had severe obesity, just under 10% had diabetes. And it is very important to study in these specific populations because you want to make sure everything is safe in those populations. The interval between these doses was 28 days. So the vaccine efficacy for that was 90% 14 days after the first shot, but then that second shot gave it that longer term protection and it bumped it up to about 95%. So the Johnson & Johnson EUA, this one was granted in February 17th of 2021 for 18 years and older. On October 5th, they submitted an application to the FDA for a booster shot for the COVID-19 vaccine. And that this one being the one-shot deal, booster shot was always going to be considered for this one because, again, most vaccines, we have a prime and then a boost. And we were thinking with the Pfizer and Moderna, we were getting a prime and boost within a month. But boosters are most effective if they're given over 6 months after the original injection. So we were probably always going to get a booster for any of these. But Johnson & Johnson was the one that we talked about most often. So the data that they submitted showed that a second shot of its vaccine given about 2 months after the first significantly boosts protection. It was originally about 75%, and it boosts it to as much as 100% against moderate to severe disease. So, but they also released data showing that a booster prompts an even stronger immune response if it was given 6 months after their initial shot. So again, this one, we've always been studying a booster, but now we're finding out the 6 months after their original shot, you get a 12-fold increase in antibodies versus a 4 to 6-fold before the shot. So this one is going to be discussed on Friday, the 15th, amending the emergency use authorization for a booster dose in individuals 18 years and older. And this original study, again, this is a one-shot deal. 44,000 participants were randomly assigned. The endpoints were prevention of moderate to severe COVID-19 illness. And this one is, a lot of people were talking about how this one had a lower efficacy, but we have to remember this one was being studied at a time when we had more variants. So this one, in a sense, was more rigorously tested against a lot of different mutations, if you will, of the coronavirus. So it showed an overall efficacy of 66%, but that was probably lowered because it didn't have as good effect against the South African variant. And it was studied heavily in South Africa. So generally in the United States, we had about 80% efficacy in preventing severe and critical illness because we didn't have some of the mutations that it wasn't as successful against. And those ones have kind of all died out and Delta has raised to prominence. So all of the vaccines that we have that are authorized are effective against coronavirus, at the most important part being preventing severe disease and hospitalization. So FDA approval, again, we talk a lot about emergency use authorization and approval. They're pretty much identical except for one small piece. The final step in reaching FDA approval requires them to submit a biologics license application, and this requires 6 months of clinical data that prove that a vaccine is safe and effective, as opposed to the 2 in an emergency use authorization. So approved vaccines also continue to be studied in long-term clinical studies. They call them clinical trial phase 4. To better understand risks and potential benefits of the vaccine over a time span of many years. We haven't been in the COVID pandemic for a lot of years. It feels like a lot of years. It's really just under 2. So these vaccines will continue to be studied for lifetimes. And so far, the only vaccine that has received full approval is the Pfizer and BioNTech. And the full approval is not for 12 to 15. So that will come in time as more information comes over. So they got the full approval on August 23rd for 16 years of older. The vaccine is now marketed as Comirnaty, which is really difficult to say. They were looking to kind of marry the words community, immunity, and put RNA in there. Successful, but really difficult to say. The vaccine remains under an EUA for 12 to 15 years of age, as well as for the booster shot. But again, I expect them to file for full approval for that age group as well. So the US vaccination numbers I got from the CDC, and fully vaccinated in the United States, we have 187 million plus, which is just over 50% of the US population. It's 56.4% of the US population. And it did break it down by doses as well, by vaccine. So the Pfizer overwhelmingly had 102 million. That was the most that people have received in the United States. Moderna's came in second at 68 million, just over 68 million. And Johnson & Johnson, again, a late player to the game, but 14 million, that was the single dose. And again, a lot of people were looking for that single dose. They did not want to get 2. But also this was a vaccine that we could easily give to rural populations because the refrigeration was a lot easier to manage. So, and 65% of the US population has received at least 1 dose. So that's 216 million. And if you break it down by age, so at least 1 dose by age, greater than or equal to 12 years, it's about 76% of the population. Over 18 years is 78% of the population, and 65 years of age, 95% of the population has received at least 1 dose, which is amazing. Fully vaccinated, over 12 years is about 66% of the population. Over 18 years is 67% of the population. And over 65 years of age is 84% of the population that's fully vaccinated. So we're doing pretty well. We have a little ways to go, but we're doing pretty well. Massachusetts specifically, we are one of the leaders in vaccination for the country. The Northeast is probably one of the safest places to be in that sense. We have a really good acceptance rate of the vaccine. So fully vaccinated in Massachusetts is just under 5 million, which is about 68.5% of the population. They don't break it down between Pfizer and Moderna. They just kind of lump in the 2 doses and then single out the single dose. So it's about 4 million for the 2 dose and 300,000, just over 300,000 for the single dose. At least receiving at least 1 dose in Massachusetts is just under 80% of the population. So it's 5.3 million, which is quite good. So the Pfizer BioNTech booster, this is the one we have a little bit more of the information on because this one has already been authorized. On 9/22, the FDA amended the EUA for single booster dose to be administered at least 6 months after the completion of the primary series for individuals 65 years of age and older. Also, individuals 18 through 64 years at high risk of severe COVID-19, and individuals 18 through 64 years whose frequent institutional or occupational exposure puts them at high risk for serious complications, including severe COVID-19. So there is a list on the CDC website of people who might be at higher risk for more severe COVID-19. Includes people with cardiovascular disease, diabetes, obesity, smokers. There's a whole list. It's similar to what the lists were at the beginning of people who had comorbidities and were able to get the shot sooner, but it's more expansive, which is good. And a lot of the information that we had for the Pfizer and BioNTech booster that was presented at the committee meeting came from Israel. Israel was an early adopter and they almost exclusively used Pfizer. So they were able to do a booster for their population and they really showed good data on, they were having a lot of cases of COVID-19, including in people who were vaccinated. They were just getting a lot of cases. So they did a booster program and they noticed 2 weeks after the booster, their cases sharply declined. So that was really important information for the United States to see in real time what happens when you get a booster. It was, again, really important for people who are most at risk for severe COVID-19. So people 65 years of age or older, or people with certain comorbidities. And then the pediatric COVID vaccine, there was a flurry of emergency use authorization applications last week and even over the weekend. So a lot of information and a lot of meetings coming up. But on October 7th, Pfizer and BioNTech filed an application with the FDA seeking an extension of the EUA for their COVID-19 vaccine for children 5 to 11. I've personally been waiting for this for quite some time. We have almost 5-year-old, so I'm very excited. This population, Pfizer tested a lower dose. So they tested 10 micrograms, which is a third of the amount in the shots that are given to 12 and older, which is 30 micrograms. And the reason for that is children have really robust immune systems, so they didn't need as much of a dose to have the same immune response as an adult. So they noticed after the second dose, children developed coronavirus fighting antibody levels that were just as strong as the teens and young adults who received the regular strength dose, the 30 micrograms. So in anticipation of them filing an application, the FDA had already scheduled a meeting for October 26th to inform their decision making. And again, this is an independent committee who reviews all the data and makes recommendations to the FDA. The FDA then makes a recommendation. Then it goes to the CDC, and the CDC has their own group that also meets and discusses. So this is going through a lot of people, a lot of scientists, a lot of people who have dedicated their lives to studying this. And the decisions are made with a lot of input, a lot of really good input. So the vaccines do remain the best way for us to sort of get out of this pandemic and protect people, because even though there are breakthrough cases, and they are still rare, but again, if you have 187 million people who got vaccines and a smaller proportion who didn't get vaccines, you're going to have a high number of breakthrough cases because you have a higher population who did get the vaccine. So you're seeing high numbers of people who are having breakthrough infections, but that's because there's a high number of people who are vaccinated. So that's always kind of the important takeaway from that. People, we tend to look at numbers, and we tend to look at, okay, there's a lot of people who are testing positive, but when you look at the numbers and then compare it to the millions of people who have actually gotten a vaccine, that percentage is still quite low. So vaccines definitely remain one of the best ways we can protect ourselves, our families, our country from COVID-19. But when you do get COVID-19, we do need treatments. So there's a lot of treatments that are being worked on as well. There's currently only one drug that is FDA approved for the treatment of COVID-19. It's remdesivir. It's only for use in hospitalized patients who require supplemental oxygen. It is IV. So this is not something that would be easy to use for people who are outpatient. And again, most of the people who do get COVID-19 are considered outpatient. They have what's, mild to moderate disease. So this is only approved for severe disease and people who are hospitalized. We also have dexamethasone, which stops the immune system for overreacting. Again, also used in people who are hospitalized. The monoclonal antibodies is also under an emergency use authorization from the FDA for treatment of patients with mild to moderate COVID-19 in outpatient settings, but those who are at high risk of clinical progression. And there's 3 types of monoclonal antibodies. They're just listed in alphabetical order. There's not one that's better than the other. Some work better against certain mutations than others. But again, this is an IV medication as well. So we have a lot of IV medications that might work or are working relatively well, but it's for those hospitalized patients. We also use, of course, ventilators and prone positioning for in-hospital treatments. And these, again, are all in-hospital treatments, but really what we're looking for is a way to treat people at home to prevent them from going to the hospital. And that's what has recently started coming up. We have 3 clinical trials that are being conducted for COVID-19 oral antivirals. They are all 5-day regimens, twice daily. The molnupiravir study began in October of 2020. This is Merck and Ridgeback Biotherapeutics. They applied for an application for EUA on this past Monday, October 11th. This one I have been waiting for. It showed, they actually stopped the clinical trial early because it showed so much progress and so much promise that they wanted to start using it. So an independent outside investigator actually recommended that they stop the trial and just start applying for an EUA. There's also 2 more that are coming up. One is Pfizer. It's the PF with the whole bunch of numbers that I'm not going to read. That's a protease inhibitor. That one started in August of 2021, so fairly recently. There's also another oral by Roche and Atea Pharmaceuticals. That one started in May of 2020, and it started in moderate disease in hospitalized patients. But then in May of 2021, they added a second arm to that trial, which was mild to moderate and non-hospitalized, which again is the overwhelming majority of people start off as non-hospitalized, and we want to prevent them from going to the hospital. So again, they're being trialed at twice daily oral medication for 5 days and showing really good promise. So I'm very interested to see when they schedule the advisory committee meeting for the molnupiravir. And then for the influenza vaccine. So typically we have trivalent vaccines. So we have 2 strains of an influenza A and 1 strain of an influenza B, and they're all in one flu vaccine. Some committee looks at the data and figures out what strains are most likely to be sort of heightened that year, and those are the strains that are included. This year, they went to a quadrivalent vaccine. That was always available for people 65 and older, the quadrivalent, but they just, where last year was not a great flu year and we're expecting this one might be worse, they went with a quadrivalent for all flu vaccines this year. So there's 2 A strains and 2 B strains. So you have protection against 4 different flu viruses. And according to the CDC website, while there's limited data existed on giving COVID-19 vaccines with other vaccines, including the flu, our experience with giving other vaccines together has shown the way that our bodies develop protection and possible side effects. They're pretty much similar when vaccines are given alone or with other vaccines. So the short story is you can get your flu shot at the same time as the COVID-19 vaccine, including your booster shot. But if you have any concerns about getting both vaccines at the same time, definitely follow up with your primary care physician and ask them. And the only other thing I wanted to mention is, so people who receive monoclonal antibodies when they're being treated for a COVID-19 infection, the only thing that you need to worry about getting a booster or getting a vaccine for COVID-19 is you want to wait at least 90 days if you've received monoclonal antibodies before getting the COVID-19 vaccine or the booster. And the reason for that is because you received antibodies for COVID-19. That's what monoclonal antibodies are. And they could interfere with vaccine-induced immune responses. So you might not get as good of effect from the COVID-19 vaccine or the booster. So you really should wait about 3 months before getting a booster or the vaccine itself. And I think that's it. So I can stop share.
Wow, that's a lot of great information, Siobhan. We really appreciate it. And we did make a video, so this presentation will be on our website within a day or so. I had a couple follow-up questions, or maybe just like points of emphasis. The Moderna booster, you said it might be half of the dosage of the full vaccine. And I think the importance of that is that they can make more boosters, and
Yes.
more boosters will be available for people. It's only
Exactly.
a half dose, quote unquote.
Yeah.
And I guess I had seen, again on the boosters, I'd seen an article recently that the boosters, the existence of the boosters or the need for the boosters is contributing to vaccine hesitancy, because some people are saying, well, this just proves that the vaccines don't work. I don't know if you see anything like that.
I have heard that. And I like to, anytime somebody mentions that to me, I like to point out there are a lot of vaccines that we get that are prime boost. I mean, if you think about the hepatitis B vaccine, you get one, and then a month later you get your second one, and then 6 months later you get your third one. So we know that boosters are most effective when they're given more than 6 months after. We may have been able to find out that one vaccine or one dose and then a second one 6 months later. So keeping that 2 shot, but spreading them out, that could have been more effective. But our goal was to make sure that we had an effective vaccine. And what was studied was a quick prime boost. And it was effective for quite some time. And it remains effective against the 2 most important things, hospitalization and death. So I think that I get that people want a vaccine and they want it to be done and they never want to see it again. And I'm totally there. But that's not how vaccines are developed. That's not how we learn as things are going on. We're in the middle of a pandemic, so we're studying something in the middle of a pandemic. And this is where we are. And we don't need a targeted booster. I think that's a lot of what people are asking, like, well, shouldn't we get a booster that's targeted for a specific mutation? We need vaccines in arms. We need people to be protected. We need it to stop spreading so much so that it won't mutate. The fact is these vaccines are still effective against Delta and are likely to be effective against most of the other ones that we're going to be seeing in the future. They may not prevent us from getting the infection completely, but they're going to keep us out of the hospital and keep us from dying at a very high rate. And that's how we get out of this pandemic.
Yeah, I think it's good to have that sort of in mind, because I think also people who don't want to take the vaccine for political reasons use the booster as an excuse not to take it too, because they have a million excuses not to take it.
Yeah, and we get boosters for a lot of things. I mean, they're you know, and the MMR vaccine hasn't been around for hundreds of years. It's only been around for 60, 70. And we're finding that people who are adults may have lost a little bit of that, the effect of that. So people are getting boosters for things that they got, 50 years ago, 60 years ago. It's just, this is how research goes. This is how science evolves. We learn more and we do better. And I think we were always thinking we were going to have a booster for the J&J because it was that one-shot deal. But just knowing that things have evolved and Delta is a little bit more rigorous than some of the other mutations that are out there, it gives us a better shot of making sure that we don't have severe disease or get hospitalized.
Yeah, if folks have questions, feel free to unmute yourself. We'll put it in the chat, whatever you're comfortable with. I did want to ask one more thing about the flu vaccine, because I think I had read that someone was working on a vaccine that had the COVID and flu vaccine in the same shot. Have you heard of that?
I have. I know that. I think that's going to be something that we'll have in the future. I'm very excited to have one less shot, but still get my shots. So we're definitely going to have that in the future. I'm not sure. It's not ready yet, but it's likely that we will have that option in the next couple of years. And just as an aside too, for the mRNA piece of it, Moderna Pharmaceuticals was actually studying an mRNA flu vaccine in 2019. It was in clinical studies. So I like to mention that to people who say, oh, this is a brand new vaccine. Oh no, we actually had a flu vaccine that was being tested before the pandemic. So it's a great technology. And I look forward to seeing what other things we're going to be doing with it.
Yeah, I think that's important to note, is that technology can be used for so many different things.
So many different things.
It's not as easy as a tweak, but they can sort of target it to whichever virus that they're.
And it's easy to ramp up the production and manufacturing, which is again a really important part when you're trying to inoculate the world.
Kathleen, did you have a question?
I did actually. We've got 2 people in my family who got the Pfizer, and neither of them right now qualify for the over 65 or immunocompromised, but they loved their Pfizer vaccine and are curious as to when they can get boosters. And I'm wondering what the timeline would be for people that do not fall into those bands currently that do want to be boosted.
And I got Pfizer too, so I'm excited to get my booster as well. The Vaccine and Related Biological Products Advisory Committee, they were looking for us to be doing more testing on that before they opened it up kind of wider. We didn't do the study that Israel did. Israel presented their data, and that was a really important piece for us to have, was to know how safe it was for people to get that third shot, that booster shot. So they are currently studying it. They're opening it up to more people. I'm hoping within, hopefully by the end of the year, they might open it up. I will say that between 18 and 64 group, it's really broad. If you look at the CDC website, there is a whole list of people who would qualify, and a lot of people actually would qualify. So it's if people are considering it and they're anxious to get it, definitely talk to their doctor to see if they do qualify for that second shot. But I'm hoping this winter we'll have more broad use of that.
Okay, thank you. And I think we have one other question. I'm not sure who it's from. New again? Did you want to ask that? I'm not sure if they're even still on. I don't see them. So I'll ask it if I can find it again. So this is an opinion question. Do you think unvaccinated people should be excluded from in-person participation with at-risk populations?
I don't think anyone should be excluded. I mean, I work for the Department of Developmental Services. We want people to be included. There are people who can't get the vaccine. It is a very small subset because the mRNA vaccines, you don't have the egg allergy that you have to worry about that you do with so many other vaccines. Really the contraindications for the mRNA is being allergic to the polyethylene glycol, which is that lipid molecule that they're using to get it in. That's the vehicle. So if you're allergic to polyethylene glycol, you cannot get the mRNA vaccine. Or if you've had like severe anaphylactic reactions to previous vaccines, which I do know some people have gotten that under, strict observation to make sure that they're okay with that. So there's very few contraindications to the vaccine, but there are religions who do not accept vaccines or, certain medical procedures. I don't think anybody should be excluded, but people who are unvaccinated are definitely at higher risk to get it, as long as they're making sure that they're doing social distancing and they're washing their hands and socially distancing. And we've gotten rid of a lot of those things because so many people are vaccinated. So it is kind of excluding people who aren't vaccinated if they're not able to maintain that. So wearing masks, socially distancing, washing your hands, being generally very precautious, generally very cautious in taking those precautions will help mitigate it. But also that person who's unvaccinated, knowing that that is a risk depending on who they're with, asking the other person to wear a mask, making sure that they're socially distancing. Following all of the guidelines and just being generally really cautious. And that includes vaccinated people as well. I mean, I still wear a mask. I have an unvaccinated child at home. I still wear a mask when I'm going out. I still wear a mask at work. I probably will for quite some time until my child is vaccinated and everyone's gotten their boosters. This is our new normal, but hopefully it won't be our new normal forever. But I personally don't like to exclude everybody.
Thanks, Siobhan. And Stephanie had a question. Stephanie?
Hi, thank you. Sorry, I'm driving, so I didn't want to have to type out the question, but I was able to add that comment while I was at a red light. My question, I work for the Boys and Girls Club in Marshfield, and when I believe it's Pfizer that's going for the authorization for 5 to 12-year-olds, when that becomes available, would anyone on the Zoom have any advice if we wanted to host a vaccine clinic of, who we should connect to offer to be a host site? Because I feel like, being a youth development organization, it would be a great ability to kind of offer that and show our support for it.
I would partner up with one of the pharmacies like CVS or Walgreens. Somebody mentioned Osco Drug in Marshfield. I would contact your local pharmacy and see if that's a possibility for them to host a clinic. That would be great.
And the other thing I would say, Stephanie, is that the DPH in the state really was responsible for saying who could provide vaccines. And because of course, it was very limited at the beginning, and there were only certain groups that could get it. But they were sort of rationing, for lack of a better term, at the time. Now we have plenty of vaccine. Now we just need to find people to give it to. But yeah, DPH will definitely be involved with figuring out where vaccines for that age group are given out. So I can follow up with you to get you some information about who to talk to at DPH. But I think it's a great idea to do it at Boys and Girls Club or the Y, or anywhere that young people are going to be. And I think schools might be involved too, but I think that a lot of that will be on a partnering basis with local healthcare providers and pharmacies.
I think I saw on the news yesterday that President Biden has told the governors to prepare for the first week of November for starting to inoculate children. And I think I had seen somewhere around 34% of parents are going to want to immunize their children right off the bat. And then, smaller numbers want to wait a little bit longer. I'm definitely in the 34%. Can't wait to get that vaccine.
We give it at our clinics, our family planning clinics, but whether or not we'll do the children's crop, my best guess is no, but I wouldn't say a firm no, but we do offer it. We offer both the Pfizer and the J&J, but I just think it's really very curious that you can't get it from your primary care unless you can now, and I'm just not aware of it, because everybody says talk about it with your primary care, talk about it, and that's where I would go to get my flu shot, and that's where I would go to get any other vaccines that I thought I might need. You know what I mean? But you can't.
And I will say it's probably because of how many doses are in that vial and the storage of it. So I think Pfizer is only, once you draw one out of that vial, it's only good for like 3 days.
Actually, it's 6 hours.
Yeah, so it's
Only
really
6 hours.
very
Yeah.
low. It might be once you defrost it, it's only good for in the fridge for 5 days. But yeah, once you start drawing it out, so you really,
Yeah.
that's where I think that's where they're thinking about not having it done in PCP's offices. And just
But-
you mentioned being a family planning clinic. I want to mention too that pregnant women are they did come out with a statement that pregnant women are at very high risk for severe disease with COVID-19. So they should get vaccinated as well.
And you don't have to be a patient of our sexual and reproductive health family planning clinics. Anybody can come and get it. And if it's somebody that's under 18, we just do need their parent to be with them, because they do need parental permission to receive the vaccine. But, and again, I don't know what will happen with our particular clinics with the very young patients, but my best guess is
smaller dose. So
yeah, my best guess is no, because our providers are not trained in pediatrics at all that I'm aware of. So my best guess is no, but hey, never say never, But again, we do offer it, and people can come right in and get it. We have the J&J, we have the Pfizer, we have lots of different locations, and we really want to get the vaccines in people's arms, and we'll do the booster too.
awesome.
Siobhan, I had one last question. You mentioned folks who get the monoclonal antibodies waiting to get the vaccine. What's sort of the guidelines for people who have had COVID and recovered? What's the timeline there for vaccines?
At the very beginning, when there was that equity issue of not having enough vaccines for people who wanted them, there was a recommendation to wait 3 months, because we know that the natural immunity from having COVID lasts about 90 days. You don't have to wait the 3 months now, especially where there's not an equity issue. The vaccine-induced immunity is much stronger than natural immunity. And especially with Delta, we're finding that you even if you had COVID prior and you have a little bit of that natural immunity, Delta was just kind of running right over that, and people were getting reinfected. So vaccine-induced immunity is always stronger and more long-lasting.
Siobhan, sorry, Kathleen, go ahead. Do you think that we're going to need another booster like next year or in the next few years? I mean, I think you kind of touched on that.
The flu virus mutates very quickly, which is why we get a flu vaccine every year. That one mutates just really quickly. Coronavirus don't mutate as quickly. It is mutating a lot right now because there's billions of people in the world, and not everybody, especially in other countries. I mean, we have 56% of our population is fully vaccinated. There are countries that have less than 1% vaccinated. So being that it's out there so much, it is mutating a lot more than typical. But typically coronaviruses don't mutate that quickly. So maybe my thought might be like every couple of years, maybe for a new mutation. But I personally don't think it's going to be every year with the flu, but it might, depending on how quickly we can get people vaccinated and stop the mutations.
Kathleen, did you have a question?
That was my exact question. Thank you, Nancy. Thank you, Siobhan.
Minds think alike. And again, people were kind of worried about how quickly we had these vaccines developed, but the vaccine research was built on previous coronavirus pandemics, which did not thankfully become worldwide pandemics, but the SARS and MERS outbreaks, 10 to 15 years ago, people started researching vaccines back then. And they're so similar to, one is SARS-CoV-1, this one is SARS-CoV-2. So we built on previous research to develop these vaccines, but unfortunately, it was probably going to take a worldwide pandemic to get a coronavirus vaccine, and an mRNA one at that, developed so quickly. You had trillions of dollars being funneled into research, which is how we get things moving.
Right. Any other questions? I know we're coming close to 10 o'clock and folks have to drop.
Mike, this is Trudy. Just a quick comment. Actually, my brother-in-law works for Pfizer. And he said the same thing, that, this has been a decades-long research project.
Yes.
So when people speak about the vaccine being so new, and that's why they're afraid, but at the same time as well, just to give you an idea of the urgency of it, he said 60,000 of Pfizer's staff were pulled out of their regular jobs to work specifically on this vaccine.
Wow.
Oh yeah. It's, just the mountains that these companies moved to get this going is amazing. And they took a lot of risk in that if what they were developing didn't work, they were losing a lot of money. That's the risk that people were taking was, they put a lot of feelers out, and there were a lot of vaccine trials that were abandoned because they didn't work. But you're not going to get that outside of a pandemic. You're always going to take things slower and make sure that, you're putting all your eggs in the basket sequentially instead of throwing them into 16 different baskets and hoping one of them pans out. And that's what we did. And thank God we have some really great vaccines.
And, to give it as a comparison as well, I was born just after the polio epidemic, but I have older siblings that were born right at the height of it. And, you can look back all those decades ago and really compare it similarly in the fact that the vaccine then was also new. But I'm so grateful that my parents trusted the science because, I know personally people that were impacted with polio, and it was a lifelong debilitating, disease. So, and that's the only reason why we got out of that epidemic.
Yep. And people lined up to get their children the vaccine.
Right.
And it, like you say, it was new. It was a newer technology, and it took them years to develop that. Years.
Well, Siobhan, thank you so much. If there are no more questions, there are a lot of great comments and a lot of thank yous in the chat for all this information. As I said, we'll be posting the video, and maybe Siobhan, we can post the PowerPoint if that's okay, because I think people will want to take that info, and we can send it out as an email. Might be easier for folks to access it that way. Thank you so much, Siobhan. This is great. If anyone has announcements, my one thing I just want to say is that we are very thankful to all the groups who took part in the health fair at the Plymouth Public Library back at the end of September. We kind of co-sponsored that with the library, and we had a great turnout. Had about 20 different organizations represented, and I'd say we had between 75 and 100 folks cycle through the health fair between 11 and 1. And it was a beautiful day. It was supposed to rain, but the sun came out. So the weather gods smiled upon us. And I especially want to thank BID because they had a big display of an inflatable lung, two inflatable lungs with the heart inside. And if the parents were driving by with their kids from South Street, it looked like a jumpy house. So everyone pulled in to check it out. I think we kind of did the bait and switch on getting people in for see the jumpy house that was not. But no, it was a great day. I got to talk to a lot of different folks, many folks who join us on these meetings every month. And it's always good to share resources. So we might be hearing from some of those different groups over the next couple months. But does anyone have any announcements or anything they want to mention? Or if anyone wants to introduce themselves?
I would just add, Mike, if I could, that we're trying to be more active on Facebook with SSCPP. So if your organization or you personally want to follow us and you don't already, we would love to have you on there. I can pop it right in the chat, but it's CHNA23 on Facebook is our handle. And we would love to have things shared and share things from you as well if you'd like to tag us. Thanks.
Thank you, Kim. Yeah, and Kim and Bethany, our health literacy coordinator, have been working on a sort of a monthly spotlight, which is on our social media. So please do check that out. So it always helps to like and share and comment and all that stuff to help with our social media engagement. We also talked a little bit about doing short videos. So if anyone has any desire, if they already have a video that they've done that's like a minute or two that they want to share with us to talk about something that they're doing, you know, on social media, videos are the gold standard, I guess, because everyone wants to check out videos, but not, unfortunately, not a 90-minute meeting like this one, but like a 90-second video. So if anyone has any interest in that, please do be in touch with either Kim or myself or Bethany, our health literacy coordinator. Any other announcements? Just checking the chat. Kim put the Facebook page in the chat, so please do check that out. Well, I thank you all for being here, and we will be back in November. We're going to have a presentation from a cultural broker to deal with on how to deal with patients, consumers, clients who are deaf or hard of hearing. I want to thank Amy Sylvia from South Shore Resource Center, Resource and Advocacy Center, who pointed us in the direction of this presenter. So thank you all and have a great October. Enjoy this lovely fall/summer weather. Thanks, everyone. Have a great day.